Our next category is healthcare. So we have 3 presentations under healthcare. The first is Kai.
Hello, everybody. Can you guys hear me okay? Okay. My name is Kai, and I am a senior at the University of Arizona. My majors are French and physiology, and I am a part of the Sonora and UCED undergraduate certificate program. So this semester, I worked with Dr. Bassford and Valerie Mata, who was program case manager, on this research project called Analysis of Adherence to the Screening Recommendations in a Population with IDD through Medical Record Review. So what motivated this internal quality review was the fact that previous research or existing research currently shows that individuals with and without disabilities have a discrepancy regarding if they meet preventative healthcare screenings or not. And this can vary depending on other factors as well, including the severity or the nature of the disability, an individual's age, race, ethnicity, their marital status, where they live, their geographic location due to accessibility, as well as socioeconomic status and if they have insurance or not. And most of the research that's out there had studies on women, particularly with and without disabilities, and specifically looking at breast and cervical cancer screenings. So reviewing the literature there motivated this project. Some of the barriers that were proposed for this discrepancy between individuals with and without disabilities for preventative health screenings were accessibility, lack of communication between either like provider and other professional support and patients, transportation, and some of the other factors that I mentioned before, the demographical factors. So the objectives for our research project was to evaluate how many individuals were meeting screenings or not, and these patient lists that we had were a part of a model coordinated primary care program for adults with individuals with intellectual and developmental disabilities under family medicine, in a family medicine teaching clinic at the University of Arizona. And just a little bit more on the program is that the program elements include access to care, physical accessibility, case management, visit templates, quality reviews, and staff and provider education. So we looked at this particular group to see who was meeting preventative screening recommendations according to the U.S. Preventative Services Task Force, or USPSTF for short, as well as which screenings in particular were the most often missed or met. So the methods for this research, first we conducted a literature review to see what was out there in terms of information and screening. And like I said before, most of the research was done on women, and they looked mostly into cervical and breast cancer screenings, which are the most common, with colorectal probably being the next. And then after that, we created a database in the REDCap program and used unique identifiers to track patients, because the patient's information was being abstracted from the medical records in Cerner. So after creating unique identifiers, there was data abstraction, and the main sections of the REDCap database were, we had a demographical section with information such as an individual's biological sex, their ethnic background, their age range, and who their insurance provider was. And then the other main section of the database were the screening data. So this section was a little longer, and it included screening data for breast cancer, cervical cancer, colon cancer screenings, as well as screenings for abdominal aortic aneurysm, abdominal blood glucose, and type 2 diabetes. Aspirin use for prevention of cardiovascular disease, hepatitis C, hypertension, weight loss prevention, and tobacco interventions. And then the last section was immunizations, to look at where patients were with meeting immunizations, and the immunizations that we included for abstraction were for haemophilus influenza type B, hepatitis A, hepatitis B, HPV or human papillomavirus, influenza, as well as tetanus, diphtheria. And we used the USPSTF screening recommendations from their website. There's a list called A and B recommendations list that gives the criteria for if an individual would be eligible to have the screening performed. So we used their list to determine if an individual was meeting criteria or not. And then after the medical records were all abstracted, we exported the data and performed data analysis, and that's how we derived these graphics that you see. These are not all of the findings, but these were the main ones that we were looking at from the medical records from our patients. So what we found was that overall, there were a lot of patients that had the status marked as not applicable because their demographical information, like their age range or their biological sex, etc., made them ineligible for necessitating a certain preventative health screening. And what we found as well was that from the cancer screenings, the breast screenings had the highest compliance rate, with a compliance rate of 93%. And then after that, it was colorectal screening with a percentage of 58.3%. And then lastly, cervical cancer screening with a percentage of 42.5% compliance rate. And these were better than what the literature had found with the general public with disabilities. So for this particular group, our compliance rates were higher than the general public for individuals with disabilities meeting preventative screenings. And for the interventions, weight loss interventions had a slightly higher compliance rate than tobacco interventions. So for weight loss interventions, we had a compliance rate of 51.4%. And then for tobacco interventions, it was 46.7%. And then for immunizations, influenza had the highest compliance rate, very high compliance rate of 98.9%. And then the HPV compliance rate was greater than half with a compliance rate of 63.6%. So a lot of numbers there, but the graphics kind of help visualize results a little bit better to see where the patients were at with meeting screenings. One of the limitations for this internal review was that many of the records in Cerner did not have information related to preventative health screenings or their history for screenings or immunizations. So in this sense, it was difficult to differentiate whether an individual was not meeting criteria because they had not had a screening or immunization, or if simply their information was not stated in the medical record. So it's difficult to pinpoint why that may be. They don't have a screening that was performed. So with this information, these findings may be implicated in clinical practice to refine interventions and also to lessen the non-compliance rates in screening for preventive health screening among persons with disabilities. So I would like to thank Dr. Basford, JC, Valerie, and thank you all for listening as well. Thank you.
Thank you, Kai. Our next presenter is Brianna.
So my name is Brianna. I'm a U of A alum from the class of 2018, where I studied neuroscience and cognitive science, and I was a USAID trainee. I've since pursued my master's in orthotics and prosthetics, and I'm currently doing my research residency in prosthetics here in Tucson. And I'm doing a clinical fellowship with the USAID to help facilitate my research and continue to get mentorship. So for the study I'm working on right now, I'm continuing a study I performed for my master's thesis. I was noticing during my master's education that when we were discussing people with below knee amputations, or BKA, everyone assumed that the knee joint was completely intact. You know, the patient still has the knee joint, so it should be functioning fully and isn't really considered in clinical recommendations during the education. So for my research, given my background in neuroscience, I started thinking, hey, a lot of the nerves involved in proprioception rely on muscle tension, which is altered during amputation because the muscles are cut. So I don't think it's something we can take for granted as to whether the knee joint's proprioception is still healthy. So I designed a study to measure the knee joint position sense in amputees with unilateral or one side of an amputation below their knee. I recruited 4 and performed a joint position reproduction test. I used, because this was an unfunded study at the time, a laser pointer and trigonometry to determine knee joint angles. And that was a lot of math that I regretted when I was writing this paper. And the goal was to investigate whether they had pathological knee joint position sense loss and whether that loss was different or greater on their amputated side versus their unamputated side. The study size was fairly small, only 4 participants, but because the study was within subjects, so the subject had both the control in their unamputated side and the experimental group in their amputated side, I was able to get a really strong signal that indicated that my participants did in fact have reduced proprioception in their knee joints on their amputated side, which is again something we're not considering in prosthetics education, and it's something we're certainly not considering in clinic. So it really demonstrated to me 2 things. First, it's really important to consider or to continue clinical research to challenge assumptions in health education and assumptions in physiology to continue to improve patient care and overall health outcomes, because amputees aren't the only one who experience this proprioceptive changes, and we would see it in patients with anything from arthritis to CP or stroke, and it's something that's currently very understudied. The other main takeaway that I took from this study was that this reduced knee joint position sense could lead to increased fall risk. So now that it's something I can consider when I'm treating my own patients with amputations. So currently, I am doing a larger version of this study. This study only had 4 people. I was very busy in grad school. So I wanted to do it bigger now that I'm in my residency and I'm working with patients who would make excellent participants in the study. Currently, I'm in the data collection phase, but I've recruited 10 participants, which is over double the study size of my pilot study. So I'm very excited to see if the trend continues. And I'm also researching whether other factors that I hadn't been able to consider previously, such as prosthetic suspension method and time since amputation and limb dominance, I want to see if those factors play a role in their proprioception as well. So I'm really looking forward to completing my data collection phase and crunching some more numbers. And this time I got a goniometer, so I don't have to do math quite as difficult as I did for my master's degree. I think that's, oh no, I would really like to thank JC for helping me set this collaboration back up 2 years after I graduated. It's been wonderful working with the USET again and the University of Arizona. and also Dr. Duncan, who's been mentoring me both as a clinical researcher, but also as a young scientist. And I've been really grateful for his guidance as well. So thank you very much.
Thanks, Brianna. Okay, our next presenter actually couldn't be here today to join us live. So she did submit a recorded version of her presentation. So I'll bring that up now. You guys make sure you tell me if you can't hear it.
Good afternoon. My name is Jackie Hoffman. I am a graduating fourth year medical student at the UA-Com Tucson. So tonight I am going to talk to you about a project that I've worked on over the past 2 years through my medical track called medical education. It is development of a fourth year medical student elective in disability medicine. So some background information, as you can see, a large portion of individuals, so 6.5 million people in the entire United States have IDD. Within our state, more specifically, approximately 60,000 children and 100,000 adults have intellectual and developmental disability. This population faces many barriers, which include but are not limited to the following: lack of accessible care, patient-centered care, time-limited appointments, provider perceptions and biases. And then something that is a little more dear to my heart is the lack of adequate or formal training in disability medicine in US medical schools, despite the fact that most physicians will be seeing patients with IDD. So I am now going to tell you a little bit about the project development. So the National Curriculum Initiative in Developmental Medicine, otherwise known as NCIDM, is a multi-year initiative that basically to define and integrate the concept of developmental medicine into medical school curricula in the United States. So as of now, there are 18 medical schools and there have been 4 cohorts, and our College of Medicine was lucky to be named in the 4th cohort. In terms of developing the elective, it's called The Care of Individuals with IDD. So I did a thorough literature review. I developed a syllabus with Dr. Basford and Lynn Tomasa. I presented the course to TEPSI, which was approved in last fall. And now we have students who are enrolled to start in July. Just a little bit about the course. The objectives essentially are for students to develop knowledge of the physical, emotional, and social needs of adults with IDD through the aging process. And we want students to become familiar with the family, work, social, and community resources available to support the patient's goals. So the course has multiple components, really across medical knowledge, patient care, and communication skills and professionalism. A big chunk of the course, which is important, is engaging with local community partners, which is very exciting. So students will not only be in clinic and working in the medical capacity, but they will be working with organizations in Southern Arizona committed to helping individuals with IDD. High-level kind of overview of the assignments. There will be daily lectures ranging from everything from guardianship to actually a review of Down syndrome, cerebral palsy, etc. Students will be making home visits, attending clinics, and they will complete a 1-page reflective paper in addition to completing pre and post NCIDM surveys. Looking forward, we really look forward to piloting this summer, and we will be going through a process of getting ongoing feedback from the students who go through the course. And ultimately, we'd like to expand the cohort and implement additional surveys. Thank you so much for your time.
If you have, since she is not able to answer questions about her project, her contact info is listed on her poster, and all the materials will be sent out within the next week or so. So let's see. I think that was our last one for healthcare. So do we have any questions for Brianna or Kai?
I guess I was kind of wondering what you thought contributed to the compliance rates of the screenings, like with the breast cancer one being highest.
Yes. So I mean, I'll give you my best guess just from like a logistics standpoint, because we don't have any like explicit information saying like why one was better than the other, but I think it has to do with the invasiveness, and also especially something that came up in the literature a lot was there's an assumption that individuals with disabilities are not sexually active, and so people assume that it's not necessary or applicable to conduct pap smears, which could contribute to the lower, and overall in the general public, a lower cervical cancer screening. And yes, that was interesting finding, because according to the USPSTF, the age range for women for breast screening was I think it said 50 to 64 years old, unless you have a family history of breast cancer, then they recommend earlier. But and for cervical screening, it's 21 years old and above. So that and that also could have had to do with the population that we had too, because the age range of our population, a lot of them were older, so a lot of them did have mammogram in their records. So I hope that answers your question. Thank you for the question as well.
So in the chat, we had a similar question, and Lori and Julie had the same question. So thank you, Kai. There's also a shout out to Brianna for her impressive using a laser pointer in trigonometry. But now you have your goniometer, if I said that correctly. So hopefully you won't have to do too much this time around.
You did. I was grateful now that I have an income. I was able to spend a little bit on my research, and there are a couple O&P grants that were put on pause because of the pandemic. But I'm hoping for next year when I do my orthotics residency to maybe apply for some grants and see where we can go from there.
Great, thank you.